Thank you, Ellen. I appreciate it. Thank you all for coming tonight, and thank you, NAMI, for being such a wonderful resource for all of us in our community. Tonight's topic is about sleep. It doesn't mean we have to be bound to that. We can certainly talk about mental health conditions in general in kids. Certainly, mental health conditions and sleep tie together. And I know that we want to make it interactive, so please, along the way, if you have questions, please ask. If you have your own experiences you'd like to share, we could all learn from that. I'm going to go through some of the sleep guidelines. I'm going to share a little bit about some of the studies that exist out there, although there are not that many. I'm going to kind of talk about some media use recommendations, sleep hygiene guidelines, a little bit about melatonin, which I know has been used a fair amount. And one of the things that wanted to be mentioned is about kind of when to look for a sleep study. Now we have a pediatrician in the audience today, and it's nice to have her, and we'll certainly get her input along the way too. So just to start with, the American Academy of Pediatrics Sleep Guidelines, and you should all have a handout on this. It was over there. If anybody doesn't have it, then please raise your hand, and Ellen will get it for you. So from ages 4 to 12 months, the guidelines are to have 12 to 16 hours of sleep per 24-hour period. That would include naps. For 1 to 2 years, 11 to 14 hours, including naps. 3 to 5 years, 10 to 13 hours. 6 to 12 years, 9 to 12 hours. 13 to 18 years, 8 to 10 hours. How many teenagers are getting 8 to 10 hours of sleep out there? So we're probably falling short of that in a lot of the cases, but those are the American Academy of Pediatrics sleep guidelines for us to aim for. And as I'll kind of talk here in a moment, there's good reason for that. Adequate sleep is important in so many areas. And the big question is why? Adequate sleep leads to improved attention, improved memory, behavior, learning, emotional regulation, quality of life, and mental and physical health. And if any child or teen out there is not getting adequate sleep, and even a portion of those things that I just mentioned are off, then their functioning is going to be compromised. And so a good place for us to start from the get-go is to try to get kids the adequate sleep that they need. In fact, to comment a little bit about the point we just kind of kidded about, is that in 2007, the Centers for Disease Control did a youth risk behavior survey, and in fact showed that 70% of high school students average fewer than 8 hours of sleep on school nights, and 40% averaged under 6 hours. So as I said, not many studies on the association between sleep and mental health exist, but let me go through a handful of findings from those that are out there. One study looked at 139 3 to 7-year-olds who had significant sleep problems. And by that I mean restless sleep along with morning tiredness, difficulty getting to sleep. 32% of this population had significant sleep problems, and it led to increased intensity of psychiatric symptoms, particularly through the child behavior checklist that parents filled out. These kids that were not getting the sleep that they needed were far more emotionally reactive. Along those lines, 3-year-old children with regular bedtimes, if we could flip it around a little bit, 3-year-old children with regular bedtimes, meal times, and limits on television and video time had better emotional self-regulation. So there's risks associated with not getting enough sleep, and there's benefits associated with getting enough sleep. Lack of regular bedtime in this group and poor emotional self-regulation at age 3, as they looked at it in the years to come, predicted more obesity at age 11. In this study, 40% of these 3-year-olds had regular bedtimes, 47% had regular meal times, and 23%, about a quarter of them, had less than an hour of video or TV time. And those kids fared better in terms of their outcome. Another study looked at preschool children who had TVs in their bedroom. Actually looked at 100 of them. And they had more sleep terrors, more nightmares, more sleep talking, and they felt more tired in the morning. Interesting point about this, the total sleep time and total TV time were no different in this group. It was a matter of that they had the TV in their room and therefore were more prone to looking at it at night. And these are younger kids. Sticking with the preschool age population, a delay in sleep onset and refusal to sleep alone predicted depression and anxiety severity over the subsequent 6 years. It did not predict ADHD severity, however. And these were 292 kids, and parents filled out the preschool age psychiatric assessments. And this is the younger population. So another point is the bedtime use of media devices, such as cell phone and tablets, are associated with poor sleep quality and excessive daytime sleepiness. This was a result of a meta-analysis of 20 different studies, 126,000 kids. Now, interesting also, access to, but not using that media device in their room also predicted poor sleep quality. So getting that device out of the room is important to resist that temptation, and it's another indication, a signal to these kids that it's time to go to bed. Substance use can be impacted by less sleep. Study looked at, and these were 310 Western Pennsylvania boys, less sleep age 11, associated with earlier and repeated use of alcohol and cannabis intoxication throughout adolescence. They looked at these boys and they followed up with them when they were 20 and 22 years old. Now, something that's gaining momentum in some parts of the country that may expand is later start times to school. Anybody kind of hear about this? Kind of any thoughts on the matter? I'll go through, what this study's found, but one particular study looked at teenagers at school that they moved the start times to 8:30 or later, showed fewer depressive symptoms, fewer motor vehicle accidents, and better academic performance than their sleep-deprived peers. And this was five public school districts in 3 states, 9,000 students in grades 9 to 12, additional 500 in grades 6 to 8. A specific middle school student start times before 7:45 had deficient sleep in 45% of the cases, and associated with that was lower academic performance. So, again, this is something that may broaden. These states were out west. Wyoming was one of them. And in terms of the fewer motor vehicle accidents, they found that those, over the period of time that they looked at, decreased by 1/3, 23 to 7, or decreased by 2/3, 23 to 7. So those are some of the peppering of some of the things that I found, and when I was looking into what evidence out there for good sleep there is. But you probably don't need to look very far outside your own homes to know, in kids that you see, your own kids, others, what the impact of a poor night's sleep is, one, or a pattern of poor night's sleep. Has been very useful in helping parents along the way with that. There's also at UH a couple sleep specialists, Dr. Carol Rosen and Dr. Carolyn Landis. That's at UH. I know there's probably counterparts at Cleveland Clinic as well. And ultimately, at the end of the handout, I recommend talking to your primary care provider, because I'm sure they have referrals for sleep or certainly mental health in general that they're accustomed to offering. The American Academy of Pediatrics media use recommendations. Children younger than 18 months no screen time apart from some video chatting, like Skyping their parents, FaceTime, because these younger kids really need the hands-on social interaction um, for their adequate development. Ages 18 to 24 months, choose high-quality content and watch those programs with kids. High-quality content like pbsforkids.org is a good resource. Sesame Workshop is another good resource. For ages 2 to 5 years, again, this is the American Academy of Pediatric recommendations. Limits screen time to 1 hour a day. Older children, they, a little bit general about consistent limits, and getting adequate sleep and physical activity is an important part of that equation. So again, it ties back to getting adequate sleep. And just to reiterate, having the media device in the room, even if it's not using it, can have a negative impact.
A parent asked, "My son gets up about 5 a.m. in the morning, and unless I give him screen time, he'll wake up the rest of the house. What do I do then?"
Yeah, you do have to think about the other kids in the household. And if they're, if one child's getting up early, unless there's a quiet activity that that child will engage in, then everybody's up. Mom, dad, brothers, sisters. So, it's not that no screen time is, recommended. And maybe that hour of the day is where that screen time becomes most valuable for everybody in the house.
A parent asked, "Should I put my child on clonidine or should I put him on melatonin?"
Yeah, I tend to start with melatonin first, and if that's working, then stick with it. But clonidine, I also use a fair amount. Um, some, yeah, and I was going to say most of the time, with either, most of the time I don't see them being overly tired in the morning, rather more rested. When we get into other medication options that may be being used for mood stabilization as well as sleep, sometimes they feel a little groggy in the morning. But melatonin and clonidine. Sometimes we use trazodone as well, but melatonin and clonidine tend to be the more popular choices to helping kids sleep. And if for an ADHD child, we also may be using the extended release version of clonidine for their ADHD, which is FDA approved for ADHD, as is Intunib. So if they need that medicine for the ADHD and it also helps them sleep at night, then that's perfectly fine. It's interesting. A lot of times you hear extended release and it defines once a day. The clonidine ER ADHD medication is actually a twice a day medication, and it runs from a dose 0.1 milligram twice a day to 0.2 milligram twice a day. But it's not unheard of to have a child be on 0.1 milligram in the morning and 0.2 milligrams in the evening. And that 0.2 versus the 0.1 can help with sleep. It's FDA approved for ADHD on its own, clonidine ER and guanfacine ER, or it's also FDA approved for use with a stimulant. If you look at studies on clonidine ER and guanfacine ER, they show coverage of all ADHD symptoms. I can tell you in practical use, you'll probably see if you have somebody on clonidine ER or guanfacine ER that they are also often in conjunction with a stimulant, because stimulants tend to do a better job with that core focusing piece. The clonidine ER and the guanfacine ER tend to do a little bit better job at the hyperactive impulsive side than they do with the core inattention. But one benefit that could come out of the combination of the two is your stimulant dose could come down, because sometimes you reach a dose ceiling of a stimulant medicine. Beyond that, they are either their appetite drops considerably, they may look more zoned out. So being on that second medicine may allow you to get down to a dose that's well tolerated while also adequately addressing the ADHD symptoms at hand.
A parent asked, "Will these medicines cause my child to lose weight?"
No, the clonidine ER and the guanfacine ER are pretty much weight neutral, appetite neutral. Shouldn't go up or shouldn't go down. Stimulants, as we know that's one of the most common side effects is appetite suppression. Uh, just a couple things related to some of the media use recommendations. Regular physical activity is associated with improved health outcomes. The National Health and Nutritional Examination Survey showed that higher TV viewing, but not computer use for homework or, for example, or video gaming, was associated in ages 6-15 with lower physical strength, irrespective of physical activity. So even if they were getting adequate physical activity, those that were kind of in front of that screen, their actual physical strength was less so. Also, the World Health Organization Childhood Obesity Surveillance Initiative showed that in ages 6-9, each additional hour of TV or computer time outside of homework, and this was per week, was associated with increased consumption of high-fat, sugary foods. This may sound intuitive, and also passive overconsumption, as food choices did not correlate with taste preference. So kids were not eating these foods because they loved the taste. They were eating these foods because of their overuse of their computer time, and these were the foods that were most readily available. And it led to a more sedentary existence. Part of this was that the computer and TV time, or the TV time, I should say, they're also exposed to advertising. So if they're in front of the TV and there's advertising for Reese's peanut butter cups and they're handy, they may go grab a Reese's peanut butter cups or chips or whatever. So all, just pieces of information that just to be aware of. Now we hear about sleep hygiene a lot. And while there can be kind of subtle differences from one sleep hygiene list to the next, I put down some really common take-homes in terms of sleep hygiene. Same bedtime and wake time daily. Use bed only for sleeping. Turn the alarm clock away from the bed. That light of the alarm clock could keep people up. Predictable and relaxing bedtime routines. Avoiding screens, as we've been a theme here today. Avoiding caffeine. Morning rather than evening exercise. Now, some kids are on teams, and their evening game is hard to avoid. But if there is a choice between morning and evening exercise as it pertains to getting adequate sleep, go with the morning. Security object nearby, and we tell people don't get the most exciting book in the world. Look for the shelf, and I don't know if they have here at Westlake, the most boring book in the world, right? Whatever interests you the least, to have that at your bedside. Actually, on the news a couple nights ago, this was with adults, but they did have a segment that if you write lists at night, that actually helps with your bedtime. Presumably it was, okay, I'm getting myself organized for the next day. I'm already on it. I feel much more relaxed now that I have a list of something that I'm going to do tomorrow, for what it's worth. Also, keep in mind the alarm clock is just that. It's for waking up. It's not for staring at. It's not for kind of waiting around and hoping to fall asleep should have the clock turned away from them. So the alarm clock is named for a reason. It's to get up. Relaxation techniques to help fall asleep, taking deep and slow breaths, or thinking about positive images, whatever that positive image is for that child. Now also, if you can't sleep, if you really can't sleep, get out of bed. If a child is tossing and turning in bed, have them get out of bed and do something that isn't too stimulating, such as reading a boring book, and they can return to bed once they are sleepy again. So if we can all abide by that, we're good. All right. So there are cognitive behavioral sleep interventions. more applied to adults, more looked at adults, but psychologists out there would incorporate cognitive behavioral therapy in their daily practice separate from sleep. But there's some ways to think about it in a sense that it might help with sleep, such as modifying patterns of thinking. And really, cognitive behavioral therapy at its core is replacing immediate, irrational, perhaps emotional driven thoughts with more rational responses. And this can help with anxiety. It can help with depression. That's the reason it's most commonly used. But it can be applied to sleep interventions as well. It's associated with improved sleep quality and outcomes, such as not as sleepy during the day. And, as I said, it can have a dual role helping with depression and anxiety. So cognitive behavioral therapy for insomnia includes aspects that we've already talked about, such as having good sleep hygiene. Stimulus control. By that I mean having behavioral instructions aimed at reducing arousal to the bed and the bedroom. So this can go back to not having kind of the screen readily available. It can also go back to the boring book kind of theory. But also just to have it as a subdued environment as possible. So relaxation, any relaxation techniques at reducing that arousal state prior to sleep. Breathing techniques, as I said, and just general cognitive therapy aims to address negative thoughts that might burden somebody at night. Worry, such as bedtime worry, ruminating about things, and this kind of filters into or extends into the whole anxiety piece. So a lot of this, so sleep and mental health is kind of a bi-directional thing. If you're not getting adequate sleep, you're going to be more prone to depression, anxiety. If you have depression, anxiety, you're more prone to not getting adequate sleep. So a lot of these interventions are kind of tied into addressing both. Melatonin, we've touched upon it. I appreciate everybody's thoughts that have kind of talked about it so far. It's a hormone synthesized in the pineal gland from amino acid tryptophan, and its secretion is controlled by our biological clock, the hypothalamus in our brains, and it's really considered the hormone of darkness. There's a natural rise of melatonin in our bodies 1 to 3 hours before sleep, termed dim light melatonin onset, or DLMO in short. Good, thank you. That's nice. Light exposure screen shifts the dim light melatonin onset to later, which will keep kids up, as does delayed sleep phase syndrome, which is sometimes unavoidable in teenagers who are in school all day and then they have their evening activities at night and then perhaps a study session as well or whatever might be going on in the evening times. But the fact of the matter is those will delay the onset of melatonin, which in turn will delay our onset of sleep. So this is widely used, I should, to be more precise, but it is not really regulated by the FDA because it's considered a dietary supplement and not an actual medication. That said, I think in clinical practice we are comfortable using this, and doses tend to be 0.5 milligram up to 10 milligrams. And the best time to give the melatonin, this is an important point, related to the dim light melatonin onset, is not half hour before bed. It's best to give it 2 or 3 hours before bedtime. So that's a key point. Anything we take could have side effects. Most common side effects are morning drowsiness, bedwetting, headache, dizziness, nausea, diarrhea. And so those are some of the main things about melatonin. I mentioned in my experience I don't see much in the way of morning drowsiness. It is a side effect. Lowering the dose, if that happens, could resolve that.
A parent said she put her child on melatonin and he fell asleep fine, but then he would wake up about 3 a.m. and be up for the day. Another parent then commented that her child had the same experience, and when they increased the dose of melatonin, he was no longer waking up at 3 a.m.
Dosing, or, and I haven't used this much, there's extended release melatonin now, but it could be tried.
A parent said her child always sleeps with her, and she wanted to know how she could transition her to her own bedroom.
Yeah, so it may be a gradual thing, like putting a mattress right outside your room to start, and then kind of slowly inching her way back into her own room. And then once she's in her own room, if she's having trouble, you stay with her for, half hour, maybe, and then kind of let her be alone. Yeah. And there also may be kind of a token economy kind of reward system that could go into staying in your room for, 5 nights a week. And then there's a kind of a nominal reward at the end of the week for doing so. But these are also situations that, seeing a mental health professional that they can kind of voice their underlying anxiety, weekly with the therapist. Also, if there's in terms of anxiety, if there's a set time during the week where it's parent-child time to actually talk about the anxiety. So they know that regardless of how they're feeling in the moment, there is that time that's going to come where they can kind of share openly about it.
A parent said that their child fell asleep fine in their own room, but then would wake up sometimes 1 or 2 times during the night and require the parent to go back into the room to calm them down for them to get back to sleep. Many of the other parents in the audience suggested it was a similar technique to the gradual calming that we had mentioned earlier, and that the parent should go and only gradually begin to give less and less comfort as they re-enter the room every night.
Yeah, exactly. And I think that term gradual is a very important one because for somebody with separation anxiety, the true underlying fear, whether it's being away from their parent overnight or being away from their parent during a school day, is that some harm will befall that parent. And that gradual recognition that, boy, I slept through the night, mom's still up there making breakfast and, getting us ready for school, things are okay, and just bit by bit, that internal reassurance that underlying fear is not unfolding the way they thought. Mm-hmm.
A parent then said that their child really reacts very strongly when he wakes up and she's not in the room and will scream for an hour at a minimum, and was just wondering how she'd be able to handle that since it's such an extreme reaction to being alone in a bedroom.
So I would really take the tough love approach, and it may take uh, it. You mentioned it as a routine. I think it needs to become a pattern the other way, that he knows he's not going to be rescued, if you will, if he's up in the middle of the night and shouting or screaming. So occasionally you hear about kids requiring sleep studies. And the American Academy of Sleep Medicine has a nice website with guidelines. I just want to review some of the indications for a sleep study. And it's called a polysonogram. It's a non-intensive overnight exam with EEG monitoring, just to look at possible disruption in normal sleep patterns. These can look at eye movements, oxygen levels, heart rate, breathing, body movements, and kind of snoring patterns. And one of the more common reasons to have a sleep study would be for obstructive sleep apnea. It can occur in any age, but ages 2 to 6 is not unusual to have this. Risk factors being around those age, enlarged tonsils and obesity. Family history plays a role with obstructive sleep apnea also. Some of these symptoms are difficulty initiating or maintaining sleep. excessive daytime sleepiness as a result, snoring or other breathing problems during sleep, abnormal movements or behaviors during or before sleep, such as a hyperextended neck, inward rib cage movements during inspiration, and movement arousal. So all these things could be detected in a overnight sleep study. Usually a single overnight study is sufficient, and with a sleep medicine physician specialist interpreting the results, and usually the results are obtained within a couple of weeks. State for a sleep study would be narcolepsy, such as excessive sleepiness, loss of muscle tone, sleep paralysis, which is basically the feeling that you can't move upon awakening, hypnagogic hallucinations, which can be kind of hallucinations as you're trying to fall asleep. Peak onset of narcolepsy is in late teens or 20s, and that would be a reason to get a sleep study. A general term for parasomnias, which is sleep issues where there's abnormal movements, behaviors, emotions, perceptions during sleep. And these can be divided into non-REM related, and those can be like sleepwalking, night terrors, confusional arousal states, bruxism, which is teeth grinding, and REM sleep parasomnias, which is when you have a total loss of muscle tone, or you may be acting out your dreams. And those REM, rapid eye movement parasomnias, are more related for adults. So kids would have more of the non-REM related parasomnias. Restless leg syndrome is another reason a sleep study may be recommended. These are very disagreeable leg sensations, uncomfortable at rest or before sleep, and temporarily relieved by leg movement. But as you can imagine, this really impairs a full night of sleep. Periodic limb movement disorder, which are involuntary, stereotypic, repetitive limb movements that occur during sleep, usually involve the legs, sometimes the arms. But again, this will really interfere with night's sleep. Depression with insomnia, usually that's not a reason to get a sleep study, but for example, if we adequately treat depression in somebody, and part of their depression is trouble sleeping, because with depression, sleep can either go up or can go down. But if you adequately treat the depression and the insomnia persists, that might be a reason to get a sleep study. And just general circadian rhythm sleep disorders, which are basically mismatches between sleep patterns and timing and the amount of sleep that one gets, such as with time zone changes and shift work. And you can make the point that a teenagers may encounter that just by the busy schedule that teens encounter. So again, talk to primary care providers for referrals for a sleep specialist. There's probably more out there that I'm familiar with, but again, at University Hospitals, Dr. Hilla Rosen and Carolyn Landis are the kind of primary sleep team. So that's kind of what some of the kind of points I had, and the discussion was really helpful. Thank you.